Healthcare is changing, and Dr. Nancy RN is here for you. The topics are many, but each program stands on its own with 3 key action points for you to learn. Your guide to a healthier you in a changing world. Dr. Nancy RN.
Welcome to Dr. Nancy RN. Healthy you, healthy nation, healthy world. I am Nancy Valentine, registered nurse and PhD, and this show is dedicated to you, the healthcare consumer. And today we have a show on a topic that most people usually don't like to think about, and that is on palliative care, pain management, and hospice. These are words that when we hear them, we often recoil and think, not me. But today we're going to really take the mystery out of palliative care because we have 2 wonderful guests that I will be introducing to you who will really help us understand this new branch of medical care that will help you, your family, and friends if and when you need these services. So the first person I'd like to introduce today is Dr. Carl Allswede. Dr. Carl Allswede is the medical director for the Pain and Palliative Care program at Bryn Mawr Hospital, and he also has his own private practice in advanced care planning. We have another segment that Dr. Allswede has been kind enough to do for us that really explains what advanced care planning does and the special service that he offers through his consultation. We also have Kathleen McDevitt, who is his partner and a nurse. And Kathleen is a person who has really studied advanced practice nursing and started out as an oncology clinical nurse specialist. And then she went on for palliative care training and has a certificate in palliative care nursing. Both of these folks have really done a tremendous job working in partnership at Bryn Mawr Hospital and also working with Mainline Health and really spreading the wonderful services that they do. So what we're going to do is really take it one step at a time and really help you understand what palliative care is. And I want to first welcome our guests. Carl, thank you, Kathleen, for joining us today. And having worked with both of these people when I was at Mainline Health, I can tell you from firsthand experience, they are a special team. And the work that they do is like putting a pebble in a pond, because what they do to help people really resonates throughout entire families and the community at large. So I wish you would start with us and help us understand what palliative care and pain management and hospice is all about. So can you give us some basic definitions? Well,
thanks for allowing us to be here. And palliative medicine palliative care is essentially relief. It's relief in any form that is accompanied with medical care. And when I was a surgeon, I was a practicing surgeon. When I prescribed pain medicine, I was practicing palliative medicine. Mm-hmm. It's just that relief of distress, it comes in a number of different forms in a number of different ways, and it's become a specialty in and of itself.
Mm-hmm. Interesting. Now, Kathleen, you were an oncology nurse and then decided, to get into a more specialized area of oncology. How about your experience with palliative care?
My experience with palliative care actually came in my nursing training as advanced practice nurse, and it was really, if you look at the history and evolution of palliative care, it was really in its early stages holistic care, looking at the physical, emotional, and psychosocial. So long before I progressed to palliative care, I was long attracted to the model. As an oncology nurse, you're faced with a lot of symptom management. And as I entered my career in the early 80s, one of the things that I noticed in oncology, although there were a great plethora of new drugs and treatments available, that these patients weren't able to endure these treatments, and they weren't able to experience the full benefit of the full course and duration of treatment. So a lot of them would drop out of their treatment cycles and would progress on in their cancer. There were very few drugs at that time to manage these highly emetic regimens that really put cancer at that time into remission. So I was always very attracted by that, and I also had a strong curiosity, always have had a strong curiosity. And what has always made my vitality as a person and a nurse is my ability to touch lives in a unique way and to provide compassion along with that. This compassion is what fuels humanity. And what was dismantled in the illness, physically, emotionally, and psychosocially, I was able to recoil again. And this was really attractive to me. So shortly after I achieved my specialty certification in oncology, shortly after that I went up to Sloan Kettering and did a palliative nurse fellowship with Dr. Nessa Coyle, and it was quite an enlightening experience. I think the thing that attracted me the most is the first day that when we did rounds, we came out of the room after seeing the patient, and the social worker was giving tips to the physician about what they thought would recommend would better treat the pain or more in tune to some of the physical pain the patient was enduring. And when the physician started telling the social worker, I think there's some, marital issues here with I think is going on with the family, and I thought, I just love this transdisciplinary communication, that they were so in tune as a team and so complete in their discussions and assessment with the patient that they were able to provide really cohesive care, and I saw such a difference in the patients and families. I also really agonized a lot that the longest amount of time the patients and families were in their health care, they had the least amount of support. In the beginning, when it's being diagnosed, there's a lot of support, and in the end sometimes, but that long period of enduring that, or in between treatments, and all the fear and the angst that comes along with it, there was really no support. It was a very, very broken system.
I think that's true. I mean, I can even recall when I was in nurse training myself. That was many years ago, but nonetheless, I remember a really wonderful woman I took care of. She had had advanced breast cancer, but every week I would go for my rotation back to her, her hospital bed. That was one of my assignments, and she got sicker and sicker. She was more and more isolated, to the point where she had an actual curtain put around her. Everyone else was taken out of a 4-bedded room at that point.
Right.
And she was isolated until she died. There was really no intervention or no plan. Now that was, many years ago, and certainly we've advanced. But I think what I would hope you could explain to us is that most people would say, well, isn't that what my regular doctor does? Why do we need something special? I mean, why is it that we need a team or somebody else involved in the equation? Can you explain that to us?
Well, I think it is. I liken palliative medicine to very much like infectious disease. Any physician can prescribe an antibiotic, but complicated infections require an infectious disease specialist. And that's part and parcel of what any physician can do as far as practicing palliative medicine. But I think that there are certain people who are attracted to the relief of symptoms as opposed to curative treatment. These people are going to investigate not only symptom management, physical symptom management, such as pain, difficulty breathing, nausea, vomiting, things like that, but they're also going to they're going to be very much more interested in exploring the spiritual distress that a patient may be going through, the emotional distress that a patient may be going through, and if they cannot provide those relief to that symptom burden, then they'll find somebody that will be able to do so. In our team, we have both Kathleen and myself, as well as a chaplain and a social worker, and the multidisciplinary factor of that provides relief in all different forms.
That's very interesting, because I think that what you're saying is this is a partnership, that you're partnering with the physician who may be the primary care physician. It could be an oncologist, it may be a surgeon, it may be a cardiologist. And is that something that is clear to the patient and to the family, or is it sort of an invisible discussion that happens where people aren't really sure? I mean, how does it work?
Well, oftentimes that's one of the first 5 minutes of my conversations with the family is, what am I and what am I doing? Because many people associate palliative care with end-of-life care. And that is not exactly what it does. The end-of-life care is part of it, but so I explained that we're here for all sorts of different symptom relief, and in the patient as well as in the family. The patient may be taken care of just fine, but the family may be in a great deal of distress. So it is it has multifaceted approach, and there is no, and I think that's one of the problems with that palliative medicine suffers from, is it's so difficult to define what it is that we do, because there's so many things that we do practice within the field.
But I think it's really important for our audience to understand that palliative care can happen long before you're looking at anything that has to do with end of life. I mean, end of life is a very long trajectory in some cases. But if you're having pain management issues, or if you're having a long-term illness, palliative care can really help you along with that journey and make it more comfortable, is what I think you're telling us so far, that it's really an asset to have a team work with the primary care physician or the specialty physician to help really map out what that journey is going to look like and what kind of support systems you might need. And that's where you were saying, Kathleen, often there are many disciplines that come together because it's not simple. It's never just one thing. Is that right?
You're absolutely right. And I think a key point that you hit on is the isolation. And that's really what happens, particularly with pain. You know, pain is not something that we see. And you could be in pain right now, Nancy, and you could be experiencing severe pain right now, and we don't see that happening. But it has great impact in your life. And over time, when people have chronic pain, they're not able to participate in their family activities, and there's breakdown that way. They lose their jobs, therefore they could lose their medical benefits, and then it becomes more fragmented for them. And this social and physical isolation really has a great impact into the quality of how they live their life. When you talk about patients who have chronic illness, they see several doctors. They may see several doctors at one time, and they may be communicating through, you know, letters and office visits, but there's usually not an opportunity to really sit down and discuss, you know, all their goals of care and how their values and personal beliefs fit into that. And it's also very important to help them navigate the healthcare system.
Right.
You know, coordination of care, how to navigate this healthcare system. It's not so easy. And we lean on our social worker a lot of times, too, to look at options to fit what the goal would be and how we can be more compliant with that treatment regimen. But there's a lot of layers to sort through. Lots and lots of layers. And it really empowers the patient and family who are involved because we really do more punctuated listening and just trying to see the reaction to some of the treatment. But in the earlier stages, as I talked about, it helps people participate and have more benefit from treatment because they are not burdened with some of the social pieces, some of the spiritual guilt and suffering that they may have because they feel that they're putting burden on their family and how they walk through that, how they can heal themselves. I have often said, inside our bodies we have a whole apothecary available to us, and we don't tap into that sometimes. And just living well through any stage of the illness. So I think all those different pieces are important. And because of the relationships we have early on, and understanding how they respond to treatment, the intimacy that we may have in having difficult conversations because of these relationships makes for a much smoother transition at end of life, which is very, very difficult when faced with that.
Tell us about your relationship and how you work together and as team leaders and you bring other people together. Can you give us an idea of what your day is like and the kind of people that you see?
Would you like to start? Or?
Well, it is very much a I guess complementary relationship in the sense that I tend to interact a lot with physicians. Physicians like to talk with physicians, so I do a lot of communication with other clinicians. I see a lot of the patients that are in the critical care unit that have complicated medical situations going on. With my background, I can sort through those pretty quickly and figure and determine what a course of action might be, and Kathleen is there to keep an eye on me because it's always nice to have somebody with the experience and her background to say, well, that's nice. Why don't you consider doing this or doing that? And oftentimes I'll come to her because of her oncology background. I don't have as much of an oncology background as Kathleen does, and that's one of the aspects of our relationship.
That's great. And then Kathleen, do you in turn spend a lot of time obviously working with the nurses?
Yes, I do. And you know, really what's really beneficial in terms of Carl, he really starts a day and kicks it off with the rounds, which is really important because that's where we look at each individual patient, usually starting in the critical care areas because that's where the most serious illness occurs in a hospital. And he sort of gets the big picture, elicits the big picture. And then I look at all sort of the moving parts that go along with it, all the different people that are involved in that care, and looking at what some of those needs would be. Starting number one in a patient-centered model, what are the immediate needs for that patient? Because we want to immediately get in there and decrease that symptom burden for whatever that is, whether it's pain or dyspnea or just angst about what the next step is coming. And after that, it's really important to understand that the caregivers have a good understanding of what they need to do and what options are available to them and what tools would they need or what components of the treatment plan would help them meet the patient's needs more. They need to have confidence in what they're doing. They need to really understand. This is awkward for a lot of people. It's awkward. And particularly with nurses, I do spend time because there's a great intimacy to that relationship. Think about it. You're bathing someone, you're helping them with toileting. There's not a lot of barriers there, and it's in that moment sometimes after the physicians leave or after the family leaves, in those quiet and intimate moments together is when they tell you what's really on their mind. I received advice from somebody wise a long time ago, and they said that always listen 5 minutes after you think the conversation is over. For that's the part in the conversation where people really tell you how they're hurting, and just listening helps. It's not just patients and families that hurt, professionals hurt too. And Carl has taught us a lot about that, you know, how we have to be around the team and particularly physicians. This is very difficult for them because they're socialized and indoctrinated to make people better, to get better, and to cure them. And this is really difficult when they don't respond in the way that they hope they respond, or a patient's own deconditioning process that occurs through the chronic illness. And he's taught us a lot about that. Carl also has really opened up our eyes and expanded the expertise of our program in pain management as well too, which is a big issue. Chronic pain is a very big issue. Yeah. And we also see a lot of pain and addiction as well too, which is hurting in a very special way. And he has really helped educate both the team in their expertise as well as physicians. So I think we do a much better job in these really difficult cases and complex situations.
That's really very encouraging, because I think that what you're really describing is getting underneath the most obvious reason somebody could be in the hospital or a clinic or wherever they may be found. Yeah. That they come in, they may have some pain, they may have a fever, they may need some medical intervention, but you're really trying to, again, round it out to make sure that you've covered every base and really to help them move up to a better level of functioning so that when they leave, they really have a better sense of how they're going to manage this illness, because they all go home eventually for the most part, and they need those tools that they can use. The actual people need that at home. So give us an idea of like some of the resistance that you sometimes run into, whether it's with physicians or nurses or other team members or families, because what you're saying is this is still relatively new, and because people don't understand it to the degree that we're trying to help people understand it today, they may not use the consultation to its best fit. So tell us how you get around some of that.
Well, presence, I think, being there and actually doing the job and doing it correctly, and then and having other clinicians witness that and say, oh, well, maybe I could have called these people in a little bit earlier. And I think that it's teaching old dogs new tricks, and it's just being there, doing a good job, and then they see, oh, you know, this is what it is. It isn't just end of life care. It isn't just pain management. It's recently we've had some clinicians at the hospital realize, oh, you do emotional support for these family members who are suffering while their loved one is sitting in an ICU bed for 2 or 3 weeks at a time, and that is part of the services that we provide. That's
a very good point, because most people don't go back to school and say, I want to learn palliative care. I mean, physicians, nurses, they may go maybe to a workshop, but there's no requirement for anything like this. So you're really training by doing, by showing, one-on-one. So it's a one-on-one kind of experience.
It is a phenomenon that's noted, and it's been studied, that actually the younger physicians and younger nurses are quite a bit more familiar with palliative medicine and palliative care than the older clinicians and older practitioners, and much more receptive. Right. I think it's a field that is definitely going to be recognized by the clinicians who are being educated presently.
And that's a good thing.
I think so.
Definitely. Yes, it gives a jump start to your teamwork when you're dealing with people that have already heard about it and feel comfortable utilizing it.
Right.
And Carl makes a very good point that way. You know, some of it is generational just in terms of their experience, and a lot of the things that are happening in the hospital happened outside the hospital before, and patients die when they do have serious illness, and by the time they die, it's a much more chronic process. It's not an acute episodic process. So there's a longer period of time where these issues evolve. And the inclination is to get another specialist involved, but at some point you do need somebody to help navigate and to help coordinate that, to take the time to really listen and support them. And doctor, what are your goals? What are you hoping to achieve? Really what we try to do is sort of bracket reality, if you will. What is the expectation of the outcome? What are some of the concerns we may have? A lot of times we just give a warning shot about what to expect and just see, you know, throw out a feeling, a barometer there. Where do we think this is going to be difficult? Because we can develop these wonderful treatment plans, but is this really something that somebody's willing to do? Is there a financial exclusion that's going to occur, or something that it's not a good fit for them, something they're afraid of, something against in the way that they approach in the philosophy of how they live their life, and maybe it's not a trade-off they want to make. I remember at Bryn Mawr Hospital having a patient knock on my door one time who served as a volunteer. I met him before on the cancer committee, who had advanced stage cancer. And he had a great response to treatment. And he knocked on my door one day and he said, I want to learn more about palliative care. He said, I don't want to have treatment anymore. I'm really comfortable with that. And I know that may shorten my life, but I don't want to do that. I want to live my life on my terms, and how can you help me do that? And it was very difficult for his oncologist. It was very difficult because he really wanted to help him live longer, and he had great opportunity through some of the treatment, but he chose something different. So the automatic assumption is, well, perhaps he's depressed, or he needs a treatment break, or he has fatigue, or this is just some of the impact of the treatment. It's certainly after treatment that leaves you with some fatigue. But it was just part of his course and his journey, and a big part of that is how he wanted to leave his footprints and legacy on this earth, the memories he wanted to leave behind, and the experiences he wanted to have.
That's a really good point, because not only are you educating physicians, Kathleen, you work very intensely with the nurses, but you're really educating people, the consumers. And I think that that's part of what we hope will happen through this discussion today. I would like to just back up a little bit, because we've talked about how to access these services, and it sounds like lots of times it's a consultative service that the physician will ask you, the team will ask you, please help us, sort this out. How about consumers? What can they expect? Should they be coming in and asking for these services? Can they expect to have this? Most places that they would go and get care?
Unfortunately, not every hospital has a standard approach in how they provide palliative care. In our institution, that patients and families, if they want to make that request, we come and do an evaluation, understand that the very first step in that process is to speak to their physician. I understand that this patient expressed a need, this is what I'm understanding, and just to start the collaboration at that point in time. That makes no sense to go down two different paths. We sort of have to have tandem walk, through this whole process. But in some situations, they don't have specialists involved, or they may have them there for periods of time, or they encourage them to seek these services on an outpatient basis. So it is difficult, because I can't say with reasonable certainty that at every healthcare setting in this immediate area has that access. But there are, in this day and age, there are websites and where people can access to see where these specific services are and how they may tap into them based on their need. I think the most important thing is just to start talking to your physician. Right. What your needs are, and that you might be interested in this, and see if they can help pathway that. Physicians really do want to help their patients very much, and they want this support from them. They're just not sure what the value is sometimes, because it's a different approach at things. Just as you said in the introductory remarks, that most physicians who treat diseases that have a high symptom burden or a lot of pain feel that they can treat the pain, and they'll get us involved in the hospital setting when that's become a problem, where the pain is not responding the way that we had hoped for, it becomes more refractory. But we look at things differently. I had an example one time where there was somebody who, a really top-notch pulmonologist that everyone respected, and I had a great deal of respect for, and rightfully so. And he was treating a patient who was a former vet, and he had very, very difficult dyspnea, and we had tried every drug regimen and every standard treatment and every creative approach to that. And he asked me to take a shot at it, and I sat and talked with the patient for a little bit. And what I had uncovered is that he had great angst in anticipating his end of life. for he felt responsible for the death of innocent women and children in serving in Vietnam. And when we talked about that and put some provision in and some support from a spiritual sense, his dyspnea resolved and ameliorated. So it's just different ways and different approaches.
Right.
Sometimes it's difficult, sometimes it's superficial, sometimes it's just taking a fresh look, you know, a fresh look or a fresh perspective. As Carl said, we are always bouncing ideas off one another. We get stuck too. We get stuck sometimes too.
That's interesting.
I had a patient today who's a young lady who's been chronically ill with renal disease for a number of years, and she came in with an abscess, and the abscess was treated surgically, and she was in pain afterwards. The pain was, I think, more a societal sort of isolation, made her physical pain much worse. And so even just sitting and talking with her, asking her how her husband is, how her sisters are, things like that, really made a difference to her, and she was physically relieved. And she also just wanted to, she was just very frightened about how this abscess was going to affect her life, and was it going to, you know, threaten her life. And when she received the assurance that it wasn't from somebody other than her surgeon, she was much happier and received less pain meds after that.
Right. So I would think that, you know, a way of summarizing some of this is that these services are very powerful. They are really a very powerful adjunct to just getting your basic medical care for a particular disease or condition. And that it really is better to have it sooner than later, because then you really are then able to elicit all the options. And like you said, none of the options are easy. Sometimes they're more difficult. Sometimes they're very simple. But at least you have that individualized plan for the patient and the family that really helps them to open up that conversation. I think the second thing that you said is that there are sometimes barriers to this. They can be professional barriers, you know, between physicians or nurses, but they could also be the patient's barrier or the family's barrier. Sometimes they don't even know, you know, what the service is, and they don't know how to access it. And I think thirdly is how can we get people more knowledgeable about this, so that what would be, I think, perfect is a perfect world is when patients come in and they expect to see their doctor and a palliative care team member. I mean, that they really would expect that this is part of the care provision, and not just sort of see it like later on as an add-on. Do you see that world? Do you see that vision out there?
Possibly, possibly. It's certainly something that I don't want to necessarily force upon my clinician colleagues, but it would be something that I would like them to consider us partners, as opposed to any sort of adversarial relationship that they may think exists.
Right, right. But you know, really thinking realistically about the Affordable Care Act, I mean, so much of this is really looking at integration of different tools, different philosophies, different approaches to care, so that you would look at the fact that if the care is better, meaning that people have more options, they understand what the plan looks like, they have a better handle on their pain management, all those are better quality of care factors. So therefore, what usually goes along with better quality of care is lower price, because you wouldn't be coming back to the hospital as often, because your pain would be managed more effectively. You wouldn't be depressed and isolated and have other, you know, necessarily poor outcomes, you know, because you would have a better understanding, and it gives the patient more empowerment, I think, over their illness. That's really what we're getting at, right? This is a road to more self-empowerment and more options, and like the gentleman that you said, really had a thorough understanding of his options and chose not to have any more care. That wasn't done by a panel or his physician or the insurance company. It was done by this particular individual.
And I think the important thing when we got to the point in the conversation, the healing part for all of us, even the oncologist, is if he hadn't done his work, the oncologist, he wouldn't have had the opportunity to be in that state of health that he was for that long period of time. You know, he provided that peace for him, and then the next part of the journey was very personal for that individual.
Very synergistic. Well, I want to thank our two guests today, because I think that we really are understanding through our discussion together the wonderful services that are occurring at Bryn Mawr Hospital and throughout Mainline Health in palliative care and pain management. And we hope that you have learned something today that hopefully, if you need to access and use, you will know how to go about it. Thank you very much for being with us. I hope you enjoyed our conversation today and that the information will help you in meeting your health goals. Catch this program and other conversations on the website, drnancyrn.com. Or you can write to me as well. I welcome your comments and feedback. Thank you for listening and join us again. And remember, with health, all things are possible.